All right, so good afternoon, everyone. Thank you so much for joining us for this month's Teach Educational Rounds. Here with us today, we have Dr. Osnat Melamed and Iqra Ashfaq, who will be presenting on technology-enabled collaborative care for diabetes management. So we're going to begin with our land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I encourage everyone to let us know which traditional territory you're joining us from today. You can just put it in the chat. If you're not sure, you can visit the website there, www.whose.land. And you're also welcome to let us know one thing you're doing to learn or improve your commitment to reconciliation. So we'll give everyone a few moments to do that. Thank you, Karen. So hello from Treaty 72 territory of the Saugeen Ojibwe Nation. Thank you for sharing. Welcome. Give everyone a few more moments to share. Wonderful. All right. So I'm going to keep going with a couple of housekeeping slides, but please feel free to keep sharing in the chat. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for the webinar and completed the pre-learning assessment. Please make sure you've also signed into the webinar using your full first name and last name so we can track your participation. And lastly, please make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow. Please note we will also be sending out the presentation slides as well as the webinar recording to you all this afternoon. So here's a little bit more information on our two presenters today. First up, we have Dr. Osnat Melamed, who is a family and addictions physician here at CAMH and an assistant professor in the Department of Family and Community Medicine at the University of Toronto. She works with patients at the Nicotine Dependence Clinic and is also a clinician investigator with research interests in tobacco addiction and the intersections between substance use, mental health, and physical health. So thank you, Osnat, welcome. And next up, we have Iqra Ashfaq, who is a former research coordinator at CAMH in the Nicotine Dependence Service, where she worked on the Tech Diabetes project. She currently works at the University Health Network as an implementation lead and also works as a part-time professor at Durham College for the Addictions and Mental Health program. So welcome, Iqra. And Dr. Melamed just has one disclosure to report. So please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as any verbal presentation and any discussion, do not remove the need for clinical assessments or treatment plans by healthcare professionals. So with that, please feel free to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel, and please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. Although all content-related questions will be answered at the end, so please keep note of anything that comes up, and you can post that during the Q&A period for our presenters to answer. So with that, I'll leave it to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
Thank you very much, Natalie, for the warm introduction. And hello, everyone. Welcome to Teach Educational Rounds this afternoon. My name is Osnat Melamed, and I'm a family and addictions medicine doctor working here at the Nicotine Dependence Clinic at CAMH. And I'm really happy to present today with my colleague, Iqra Ashfaq, an ongoing study of technology-enabled collaborative care for diabetes management. Okay, sorry about the technical glitches, but here I am. The learning objectives for today will be to talk about the relationship between smoking and diabetes and kind of drill down a little bit about the biology behind it. Later, we want to talk about some of the challenges that people with diabetes, as well as people seeking care for their tobacco addiction, have had during COVID. And that will bring us to talk about our current study, which is a remote model for providing support for people during COVID-19 to manage their diabetes, mental health, and also address things as tobacco addiction and other substance use problems. So we'll start by talking about the relationship between smoking and diabetes. So what we want to talk about first is to really find out whether there is a link between smoking and developing diabetes. And in order to answer that question, what we researchers have done is enroll into a study a large number of patients who at baseline did not have diabetes. So enrolling a large number of patients and following them over time in order to find whether they developed diabetes or not, and then compare the number of people who have developed diabetes in the group that is smoking compared to those who reported that they were not smoking in the beginning of the study. And as you can see, there's been not just one study like that, but a long number of studies that have tried to answer that question. So following people over time to see if they develop diabetes. And what they have found in this meta-analysis that combined a lot of studies together is that if people reported they're smoking and are followed over time, their risk is much higher to develop diabetes. And it was 44% higher compared to people who did not smoke. Another questions that this meta-analysis tried to answer was, do all smokers have the same risk of developing diabetes, or could it be related to the intensity of their smoking? And keep in mind that we know that for many of the health risks, the exposure or the cumulative exposure to tobacco smoke is the one that is responsible for the health effects. So similarly here, trying to tease out whether heavier smoking will be linked with a higher risk of diabetes. And indeed, what they have found is that people who are heavy smokers have quite a substantial higher risk of developing diabetes compared to people who are light smokers. And this is coined a dose-dependent relationship. Another attempt to quantify how much exposure a person would need to be at risk for developing diabetes was done here. And you can see that over people who smoke over 20 pack years have the highest risk of developing diabetes compared to people who are lighter smokers and have had less exposure over time. So we see that there is a link between smoking and diabetes, but how can we explain this risk? What are some of the mechanisms that we can, perhaps we can see that link the two conditions? So generally speaking, there are two main pathways that could link smoking with diabetes. We talk about systemic influences and also molecular influences. Both of these pathways stem from the fact that tobacco smoke contains quite a lot of harmful chemicals, toxicants, pollutants. We all know about acetaldehyde, of course, carbon monoxide, free radicals, heavy metals such as lead and others. And all of those create a substantial damage to different body organs. And that's through the molecular pathway specifically. And we see here beta cell toxicity. So beta cells are the cells in the pancreas that are responsible for the secretion of insulin. And if the pancreas malfunctions because of a lot of exposure, for example, to heavy metals, that could affect the pancreas' ability to release insulin and potentially cause diabetes. Another aspect that we talk about is the systemic effects of smoking, and we'll talk specifically in the next slide about the effects of nicotine. So we all know that nicotine, which is the psychoactive component in the tobacco smoke, nicotine acts as a stimulant, also known as a sympathomimetic agent, which the sympathomimetic system is responsible for the fight or flight response in our bodies. And when nicotine is ingested, we see a big increase in the release of catecholamines, which would be epinephrine, norepinephrine, other hormones such as cortisol and growth hormone. And all of these influences in the body counteract insulin. And what we can see is that if a person ingests nicotine, the response to insulin would be much, much attenuated. So this means that if I'm eating a big meal and I have an increase in insulin secretion with the point of reducing the glucose in my blood that has gone up because of a meal, if I have nicotine in my system, we'll see that the glucose in the blood does not go down as well. So there is insulin resistance. The body resists the effect of insulin, and I'm left with hyperglycemia. And of course, that's a pre-diabetic state. Another thing that we can see, we talked about some of the molecular damage. Another thing that we can see is really destruction of architecture, normal architecture in the pancreas caused by inflammatory processes. So here in the right-hand side, in the top box, you can see a pathology slide of a normal pancreas, and there are islets of Langerhans. Those are the areas in the pancreas that host the beta cells, the ones that produce and secrete insulin. And sometimes people have chronic inflammatory conditions in the pancreas, chronic pancreatitis. And as you can see, if a person has that, a person who's not smoking, you can see quite a considerable reduction in the normal architecture of that islet that releases insulin. But if we add smoking into this mix as well, which causes more inflammation, more scarring, you can hardly recognize the normal architecture of the pancreas. And of course, that leads to a much reduced ability of the pancreas to release insulin and potentially causing diabetes. So we just to summarize, we talked about that, people who smoke and don't have diabetes to begin with, they are at risk of developing diabetes over time. We identified that this risk is dose dependent. The more exposure to toxic chemicals in the tobacco smoke, the higher risk that they will have. And the highest risk we see in people who have been smoking for over 20 pack years. But what about people who already have diabetes and they're smokers? What does that mean for them? So we know that the combination of diabetes and smoking is not a good one. We know that they're more likely, compared to people with diabetes who don't smoke, they're more likely to have poor glycemic control. They're more likely to have complications, both micro and macrovascular complications. And there is a synergy between the negative health effects of smoking and the negative health effects of diabetes that could lead to adverse health outcomes. So what are some of those risks that are looming or awaiting people who have diabetes and smoke? So sometimes it's referred to as a double whammy, two health conditions, tobacco addiction on the one hand, and diabetes on the other hand. Both of them independently are risks for poor health outcomes, but the combination can be very concerning. In this study, what they did is try to assess some of the added risk for people with diabetes who also smoke. So very similarly to what was done in the previous studies that we talked about, they followed people over time. And in this study, the people that they followed were people with diabetes. Some of them were smokers and some of them were non-smokers. And they compared the risk of developing a myocardial infarction. And as you can see, there's quite a considerable increase in the risk of having a heart attack, an MI, as a result of smoking in people with diabetes. Very similar results are found when they looked at the incidence of stroke. Much more likely to develop stroke if a person has diabetes and also smokes. And of course, we can imagine that if there are more heart attacks and more strokes, there's going to be higher mortality rates in people with diabetes who smoke. So definitely very concerning from the health perspective of these individuals. So when we have a person who has diabetes and also smoking, of course, it's something that's concerning, and we want to address both conditions, both help have good control of their diabetes and also look into ways of helping them quit or reduce their smoking. But we do know that the past 2 years have been really challenging because of the pandemic. It's been challenging to get care for health conditions. And the reason for that is because COVID, was quite a major force that interrupted daily routines, also obviously within the healthcare system. And I know that many of you here are frontline healthcare providers, definitely feeling it firsthand, the disruption in our ability to provide care, which reduces people's ability to access care. And we do know that both for diabetes, both for tobacco addiction, people attend primary care services to get support. Another big challenge with COVID was the increase in psychological distress. So, no, I don't think at this point in time need to say too much, because I think all of us are really well versed in this, but definitely the psychological distress that many individuals felt. If it's related to the fact that they're not, they won't be able to meet family or friends, the stresses of perhaps job loss, financial stressors, parents needing to do homeschooling with their kids. So, a lot of added psychological distress that just makes it much more difficult for me if I have diabetes, much more difficult to perhaps manage my diabetes. And also, if I'm working on quitting smoking, could just make things much more difficult. So we talk about this combination of having less access to care on the one hand, and on the other hand, having more psychological distress to make those changes that could improve my health. In the next couple of slides, I just want to share a bit of information about a bit of data that was collected during the pandemic to really highlight the challenges in accessing care, both for tobacco addiction and for diabetes. So we'll start with some of our own data. This is data from the STOP program, and I know that many of you here joining us today are STOP providers. So what you can see here is how the pandemic affected the number of enrollments during COVID. So what we can see here is that in the couple of months before the pandemic started in March 2020, there were between 400 and 600 new enrollments into the STOP program. And what we can see here in the graph quite clearly is that as the pandemic started in March, there's been a plummet, a really big decrease in the number of people that were able to access care. And enrollments went down to only about less than 200 a month. So, you know, makes it quite a considerable challenge for people to get care for their tobacco addiction. Very similarly, this shows the number of visits. And as you can see, before the pandemic, the STOP program offered anywhere between 1,500 to 2,000 visits with STOP providers across the province. And what happened during the pandemic, as the pandemic started, we can see quite a drop in the number of visits, down to about 1,000. So, you know, people having less access to the STOP program. Similarly, I want to show a few slides about the challenges in accessing care for diabetes during COVID. So this is data that was collected from primary care clinics that are affiliated with the University of Toronto. And what you can see here is that the volume, they compared the volume of visits in the first months of the pandemic compared to the previous period in the year before. And what you can see here is that not only for diabetes, but also for other chronic healthcare conditions, such as hypertension and osteoarthritis, what you can see is quite a big reduction in the volume of visits. So if I'm a person with diabetes, I have less access to see my family doctor, my nurse practitioner, perhaps my diabetes educator. And I have, there are 25% less visits. So definitely talking about those challenges to access care, especially early on in the pandemic. At the same time, we talked about how the pandemic was a source of stress for many individuals. And what you can see here that not only there was a reduction in the number of visits for diabetes, there was an increase in the visits in primary care for people with mental health conditions or stressors, for people coming more for anxiety and to a lesser degree also for depression. So definitely talking about this mismatch of less access to care, medical care, and the increase in demand for mental health care and support from our patients. So just because of kind of, many people in many organizations kind of realized quickly that this was the case, having less access for our patients to get care, and at the same time higher stress and mental health problems. So for example, the American Diabetes Association, and this is a slide from their website, they offered some guidance to healthcare organizations on how to help people manage their diabetes during COVID. And first and foremost, what they recommended was maintain that contact with the healthcare system, maintain that contact with healthcare providers. And the best way to do that, if we can't meet in person, is through telecare, telehealth, virtual care. And I think all of us have gotten really used to that in the past little while, but this is definitely a recommendation that came out specifically to support people with diabetes. Another thing that came out is really acknowledging that COVID has made people's lives more difficult in many areas, lots of changes that need to be adapted to in a very short time, and how stressful that can be. And putting an emphasis when we're talking to our patients, putting an emphasis on mental health, stress levels, diabetes-related distress, and other mental health and tobacco addiction and other substance use problems. And because there is quite a lot of literature to say that, if I'm feeling anxious, if I'm feeling depressed, I'm less likely to take my medication for diabetes. I'm less likely to eat a healthy meal. I'm less likely to be physically active just because my mind is somewhere else dealing with distress. So really focusing on, providing our patients with tools that they can help themselves to feel better and potentially help reduce some of that stress. And of course, by providing that support, what we hope to do is to get patients back on track, just like before the pandemic, with healthy eating, physical activity, and provide guidance on ways that perhaps they can do that, with the constraints of the pandemic. So, what we've done so far is really describe the background for this study and why it's important to provide support for people with diabetes. So our approach was to take a remote program, a telemedicine program, to particularly offer support for people with type 2 diabetes. And the support is situated around providing mental health, stress, diabetic-related distress support, providing additional support around managing their diabetes, especially if they don't have access to their regular primary care providers. And the group that we offered this support was a group of patients that are past stop enrollees. So these are people who have been attended stop, enrolled in stop previously. They told us that they had diabetes, and they also agreed to participate in future research, so we could contact them and offer support with this program. Now I'd like to hand it off to my colleague Iqra, and Iqra will tell you a little bit more about how we are running this study, and kind of the components that are there in the intervention of tech. So go ahead, Iqra.
Thank you so much, Osnat, for setting the stage for us here. So exactly what Osnat was mentioning, it's a feasibility study that we're going to be talking to you today about, called TECH, which stands for Technology-Enabled Collaborative Care for Diabetes Management during COVID-19. So how it worked, it was a mixed methods model feasibility study where we're recruited. Our target goal is a total of 30 participants. The inclusion criteria being at least 18 years or older, so we're looking at adults, with a diagnosis of type 2 diabetes for at least 1 year, the A1C of at least 7.5% or higher within the last 6 months, and it is a remote program, so they do need access to the telephone or the internet. That could be through computer or their mobile. We did exclude those who don't understand English because the intervention was provided in English. Those who are not able to provide consent, because as a research study, we needed to obtain consent, and those who are pregnant or planning to get pregnant during the duration of this study. So the methods of how we used and what we used online to actually facilitate this. One thing that you may have heard about, you may have actually taken multiple surveys on this platform. It's something called REDCap. For those who don't know, it's a secure web platform for building and managing online databases and surveys. Not only can you collect data, but you can also see the report in there as well. So that was definitely a great tool for us. And I'll show you a little bit more about that, a demo of what we created on REDCap. And we also use WebEx Teams. What you're using right now to join us today is through WebEx, and the Teams version is the collaborative version. So it's an easy to use collaborative solution to help keep people connected. And I'll explain why that's important for this study. So it was an 8 weeks program. So the participants will receive 8 weekly sessions by phone and or video conferencing. We did want to be mindful of the participants' preference and wanted to tailor it and do it accordingly. And we'll talk to you about a coach, but our main person and the main contact person was a certified diabetes educator who played the role as the health coach in this project. And what they helped do with their participants was help with behavior modification. So that could be, like Osnat was alluding to, smoking being a big one, especially because these participants were recruited from the STOP database. But also in addition to that, there was also a focus on nutrition and exercise as well, along with other mental health coping strategies. Then there was diabetes self-management education also provided, cognitive behavioral therapy-based psychological support, smoking cessation counseling. This would be in addition to what the certified diabetes educator was providing. There was an opportunity to provide an additional counseling to refer them to other resources. And it's roughly each session that they had weekly was roughly 30 to 45 minutes long. So what I do want to show you here, I mentioned that we used REDCap to do the surveys and the assessments. Another thing we use REDCap for is to build a tool for a diabetes educator to work with the participants to set an agenda. So Natalie, whenever you have the opportunity to please press play. Hopefully technology is on our side today.
Agenda mapping is a great tool for clinicians to use to get to know their patients better. Once you ask your patient what's of interest to them, you can actually fill it out here in the template. So for example, let's say that your patient wants to quit smoking. They also want to work on their diet. They said they're having problems with sleep and they want to exercise more. You can list all of them here. And you also have the option to highlight the ones that are the most important. Let's say, for example, your patient says they want to reduce smoking or quit altogether, and they want to start off by working on their diet. You can always come back to this template to update it and to reference it in the future.
Thank you, Natalie. I just need presenter privilege is perfect. Thank you. Okay, so as I mentioned, we had this certified diabetes educator as the central person of contact, as in other words, the health coach, who is situated here in the middle. They're the ones who are going to be communicating with the participant through phone or through WebEx Teams on a weekly basis. But who's backing up the certified diabetes educator is a team of experts, which was very important, a part of this collaborative care model of ours. That included an addiction specialist, a psychiatrist, a psychotherapist, endocrinologist, and which a very important member is a peer mentor, someone who actually has diabetes that can sit on this team and provide their perspective as well. So the certified diabetes educator, not only do they meet weekly with the participant, they also meet weekly with this team of experts virtually on WebEx Teams to be able to provide case updates and ask questions that they had about whichever participant they have questions for. So our feasibility outcomes, our primary outcomes, really we just wanted to know, is this program feasible? And we are looking at currently the recruitment, retention, so number of sessions people actually attended. Even though we offered 8, we wanted to know, are people actually attending all 8? And the uptake of the intervention, the session duration as well. The secondary outcomes, we're looking at stakeholder experience and satisfaction. This will be through focus groups and also through just one-on-one interviews. And exploratory outcomes include health behaviors, readiness to change, mental health, quality of life, and substance use. So these are all the assessments that the participants complete through REDCap. So our results as of now are preliminary results. Again, as I mentioned, we're recruiting from the STOP database. We began in May 4th, 2021, up until March 1st. These are our recruitment numbers. So we did contact 471 people from the STOP database. Out of those, 48 were assessed for eligibility, and out of those, 32 were enrolled and completed their consent. So we did surpass our target, which was wonderful. Here are just some overall results for those 32 participants. The average age we were looking at was 57 years old. Again, these are patients with diabetes, so we were naturally looking at the older population, but we did have some who were a little younger. With sex, we did stratify for sex, so we were hoping to get a 50-50% split, so we were fairly close with 48%. With ethnicity here, you can see that this is one of the limitations here, where we had 23 people, so 74% of the ethnicity was white and European. However, I will put a plug here that there is at NGS a working group, the Anti-Oppression, Anti-Racism Working Group, trying to find a way and strategize recruitment strategies so we can get a more diverse range of participants for future studies. A majority of the people were single, separated, or divorced, and majority made less than $20,000 as their total household income for the year. Okay. Here we just wanted to break down further about each participant and how many sessions they attended. Like I mentioned, this was important, and this is an important variable when we were talking about feasibility. And I will go on. So this is just showing the first 25. The next slide goes all the way up to 32. So really, overall, the summary is the intervention was well received, with approximately 90% of participants completing over 2/3 of the weekly sessions. And I will give kudos to our diabetes educator. I feel like a lot of people just really engaged with her, worked really well with her, and they wanted to continue even past the 8 is what our interviews were telling us. And you can see at the end over here, there are some people that are still ongoing. So the numbers look low. It's just because the program hasn't ended and they're still enrolled. And our diabetes educator, our wonderful diabetes educator that I was mentioning, her name is Jennifer. And this is a quote that I'm going to read from her. The tech model has created an exciting collaboration opportunity that supports an efficient and holistic approach to healthcare. Participation in the program has provided me insight and appreciation on the impact that robust clinician support serve to support higher quality care for clients. I believe bringing healthcare to clients through this digital platform has the potential to promote client satisfaction as it meets their needs and increases access to care, especially for remote populations. So I think Jennifer hit on a great number of points here, is that collaborative piece, like I mentioned with our care model, is really trying to bring all of the experts to the table, including the patient and including our patient partner. Being efficient and holistic approach. So really looking at all different lens, that including their physical health and mental health both together. Supporting high quality care for clients. We're hoping with this collaborative approach, it's high quality care and not just care in silos. And promotes client satisfaction. We're hoping to see if that does come to fruition through our interviews, and really increasing access to care. So those who live in remote areas, those who may be, during COVID-19, did not feel comfortable coming in due to the high risk of infections at hospitals. This is the way that we wanted to still give them access to care that they deserve. And last but not least, just want to end off here with some points to think about. The interim results indicate this model can recruit and retain patients, which is absolutely wonderful. We really want to know if this is feasible or not. Will people even engage? And it seems like people are enjoying it. Wide uptake amongst this disadvantaged group. Tech supports patients in managing their type 2 diabetes, mental health, and quitting smoking, along with the other behavioral changes that I mentioned as well, with nutrition and exercise. And lastly, tech for diabetes management could be a feasible way to overcome service disruptions, even post-COVID, but increased distress caused by COVID that can improve the health outcomes. So even though this was implemented during COVID, this is definitely something that could continue on past COVID as the numbers decrease, as a way to improve accessibility to care. And I'm going to turn it back to you, Natalie, for the Q&A session.
All right. Thank you both so much. Yeah, I will just change that here. So everyone's more than welcome to post any questions you have now in the chat for our two presenters to answer. And we'll try to answer them as best as we can.
I can answer that question. So thank you for the question. The question is, for those who can't see it, is the diabetes educator sessions one-to-one or group-based? We did do one-to-one sessions for this model.
And, if there are no questions for the time being, I can, maybe there is.
are you able to do a study up in the north? Nunavut.
So this is, yeah, I mean, this is a remote program. So we've had people, just join from anywhere in the province. We've had people who are locally within the GTA, but we had people who were, from up north, Sudbury and other areas. Also, just to mention that this collaboration of providers, some of us are in Toronto, like for example, myself, but our diabetes educator sits at Hamilton. And we have a patient representative who is also sits elsewhere. So this also helped us, create this collaboration through technology. But our providers do not sit at the same place, and we have the ability to reach patients who are not necessarily within our area. With regard to implementing this elsewhere, I think that one of the things that we want to do with this data that we're collecting is really show that this is an intervention that could have a really important impact in supporting people with diabetes who are smoking as well, and leverage on this pilot data and receive more funding to scale up this intervention to places like Nunavut and other places who perhaps have less access to resources. So definitely, I think that's what's planned for the future, to just scale up this intervention and having more people have access to this.
Yes, thank you, Osnat. And just to add to that, this is the second time we're using this model. The first time was with youth with psychosis, and both times the feedback that we got from the experts in the collaborative care team that met weekly was it was an opportunity for them to learn from other clinicians that they may not be able to interact with. So like to Osnat's point, her being here in Toronto and then a diabetes educator there being in Hamilton, there's a chance in real life, if it was all in person, they would not really have the opportunity to collaborate, or less likely. But with this platform and it all being remote, it increases their chances of collaborating and learning from one another. And to Angie's question, how long were the sessions? Approximately 35 minutes.
And thank you, Iqra. And I think one point that I want to add is that our diabetes educator came from the world of primary care. Diabetes educator, her background is nursing, and she's been doing this for a while now. But at the same time, I think focusing on mental health and tobacco addiction hasn't been something that, of course, done kind of just like, other providers in the community, but wasn't her expertise. And I think what really came out from this is, a lot of virtual care team meetings, between our psychiatrists, between myself, as a person who is heavily involved in helping people quit smoking. This change of skills and knowledge, information has been really helpful. And I think over time, our, diabetes educator is now well versed in how, people use patches, behavioral skills that we provide our patients with in order to reduce or, delay, distract. And I think this is a great way just to empower providers, right, to have a greater breadth of interventions that they can deliver to their patients. So it's been a wonderful experience to see this, virtual care team running and, taking part of that, in that.
Great. Yeah, we still have quite a bit of time, so feel free to send any questions over. Thoughts about using?
Yes, thoughts about using group-based sessions. Wonderful question. Actually, in our first iteration, we still did the one-to-one coaching because we found that it took some time to actually build a rapport with the health coach and actually start creating some goals and working on that. So there was benefit of doing the one-to-one sessions. But what we did also do on top of that is host webinars and have the opportunity for patients to work together. That was a plan for tech diabetes, but it didn't go into fruition for this round, but it is for the future. So it is to have the both options. So to do the one-to-one coaching, but also to have the group sessions available as well. So this could help, and maybe we triage it based off of people and how much support they do need. So those who may be more low intensity, it could be that they go into a group session. And then those who are more medium or high intensity that require more support, maybe those are the ones to do the one-to-one sessions. So definitely room to actually adjust and adapt this model to suit and fit it towards the population that they're working with and their severity level. All right, I can answer the next questions as well. Do you provide tablets for participants to use? Great question, Maggie. For this one, it was a part of their inclusion criteria to have access to the technology on their own, but it is something that we want to be mindful of, especially that COVID shed light to this, that for accessibility, not everyone has access to the tablets, the smartphones, or even the internet. So definitely something that we can explore for future models to see how can we bring in those who don't have access. I also want to mention that another piece of it was through the telephone. So we still think that that's still part of virtual care. So if they didn't have the ability to do a video call, even a phone call went a very long way. And if some people actually open up more when they're on the phone, because maybe it's because they don't get to see something, that's me speculating, and they don't see the other person, they feel more comfortable opening up. But we did find our diabetes educator still being able to build rapport with those who are connecting through phone only. And can you tell us a bit more about the technology used? Yes, so as I mentioned, so we had a variety of different options. So just to connect with the diabetes educator, it could be through the phone. We did tech checks. So for those who were willing to download WebEx Teams, we had a coordinator, so myself and another coordinator at the time, who were willing to set up the technology with them beforehand. So give them a call, see if they can download it, do a test to make sure it works so that they're comfortable with the technology, their video was working, things like that. And then REDCap was the platform that we used to collect data for the assessments. And exactly that, yes, perhaps a combo, one-to-one for recruitment and move to group. And yes, the risk assessment for level support, exactly. That would be great, a great way to triage it in the future. Thank you for your question and your comments.
And another thing that I'd like to add, thank you, Iqra. Another thing that I'd like to add was that a lot of the time we see in people who are coming for a stop, who'd like to quit smoking, but we identified that there is a mental health issue, perhaps, high anxiety or severe form of depression that's really coming in their way. A lot of the times, I think probably the most common thing I see is people who are drinking heavily. So they're coming to us because they're interested in quitting smoking. They don't seem to do too well. And then, over the course of the treatment comes up that they're, actually drinking heavily most days of the week. And I think that that's something that, a lot of the time can interfere with quitting smoking. But then, as top providers, what do we say to these patients? How do we help them? And I think that this was a strength. I mean, I have, one participant in mind that we kind of found that this was really a big barrier. Alcohol use was a big barrier for this person to quit smoking. And the diabetes educator could, approach this with compassion, really patient-centered, kind of leveraging on the interest for the person to quit smoking. Doing a bit of case management, kind of looking in their community, in their resources, because as we said, each of us were located in a different community in the virtual care team. So really doing some research around what resources are available in the local community. Liaising with a family doctor, that's also something that we're looking into. Family doctor or nurse practitioner that are taking care of this patient. Can we liaise with them? Can we provide some guidance, some instructions, and also just acknowledging, right, that this issue has come up during smoking cessation treatment. So I think definitely, when we are helping people quit smoking, improve their diabetes management, just addressing mental health and addiction concerns is really, really important for helping them make a healthy change.
Thank you, Osnat. And to add to that, Osnat, you mentioned a great point of Liaison and bringing in their primary care provider. And we found out from a lot of patients is they're not finding it helpful, and they actually find it maybe even re-traumatizing to repeat their story over and over. So if we can be that central contact person that really navigates the care, that can go a very long way so that they feel like they've been heard and the team is all on the same page.
Yeah, and I think this speaks to the value of remote care. There's been a lot of question around this. Could remote care be compassionate? Could remote care kind of replace the in-person care? And I think that, for the most part, what we see here is that, people really are happy to receive additional support, especially if they're struggling in a particular area. This could be because, they're concerned about stigma, right? And, we talked about this being an individual form of treatment when people perhaps feel most comfortable, at least in the beginning, just to connect with another provider. So, perhaps people are feeling, ashamed, feeling stigmatized to approach their regular care team. And potentially with this model of care, we can provide resources, really encourage an open dialogue with their existing providers, and just help people kind of make those changes into, healthier changes. So I think it's been a really wonderful experience to take part of. And really opens up a lot of opportunities, I would say, for the future as we see more and more remote care. Just having this collaboration between healthcare providers is something very valuable that could help patients get the right care that they need.
Wonderful. So I think if there's no other questions, we can end it here. I just want to say thank you both so much for such an interesting and important webinar. I know I learned a lot about the tech model myself, and from what I gather from the chat, everyone else did as well. So just before we head off, I am just going to go through, people are just saying thank you. So I'm just going to go through a few housekeeping slides. So I just want to remind everyone that I will be sending out the post-learning assessment as well as the evaluation by the end of tomorrow. And I also will be sending out the webinar recording and the slides by this afternoon. I also just want to take the time to let you know about our upcoming webinar on April 13th on the topic of brief solution-focused strategies for cessation. So we hope you're able to join us. And if you happen to have missed a portion of today's webinar, want to view it again, or are interested in viewing some of previous Teach webinars, an archive list is found on our website. But for now, thank you all so much for listening and engaging, and we hope you have a great rest of your day.
Thank you, everyone.
Thanks, everyone.
Take care. Bye.